The opinions expressed by ResusLogix or Dr. Montano do not necessarily reflect the views or positions of his employer, past or present.
Hey everyone, welcome. So today we're diving into one of the toughest nuts to crack in the ICU, sepsis. But here's the thing, we're going to stop thinking about sepsis as just one disease. Instead, we're going to look at it like a puzzle, unlocking the different patient types or phenotypes. And trust me, this is the key to getting our treatments right.
You know the feeling, right? You've got a patient in septic shock, you're doing everything by the book, but they're just not turning the corner. It's frustrating. And it's because this one-size-fits-all approach, it just fails. Sepsis is wildly different from person to person. So the real question we have to ask ourselves is, how do we finally start matching the right treatment to the right patient?
All right, here's how we're going to break it down. First, we'll look at the sepsis puzzle itself. Then, we'll get into the hot versus cold immune responses. We'll touch on a few other key phenotypes, then talk about how to crack the case. And finally, we'll look at the future, precision sepsis care. Let's jump in.
Okay, Section 1, the sepsis puzzle. This is all about the problem of heterogeneity.
Here's the core idea, and it's so important. All our sepsis patients are critically ill, no doubt. But on the inside, they can be completely different. You can have two patients side by side in the ICU, looking almost identical on the monitor, tachycardic, hypotensive, on the vent. But biologically, under the hood, their bodies could be waging two totally different kinds of wars. And that's the heterogeneity we have to get a handle on.
So, how do we start sorting this out? Let's move on to the hot versus cold response. Think of it as two sides of the same immune coin.
Okay, this is a great way to visualize it. On one side, you've got the hot patient. Their immune system is in overdrive, just completely out of control. It's that classic cytokine storm we hear about, causing all this collateral damage. It's a raging wildfire. Then you have the cold patient. It's the total opposite. Their immune system is just given up. It's exhausted, paralyzed. This state of immunoparalysis leaves them wide open to getting hit with secondary infections. The fire's out, but now there's no power at all.
So let's zoom in on that hot phenotype first. This is that crazy, uncontrolled immune response, the cytokine storm. Basically, the body's defense system goes from protecting to attacking. It starts damaging its own organs, and that's what sends patients into multi-organ failure. And one of the biggest red flags for this is
this number right here. When you see a ferritin level over 4,420, that's just sky high. That is a massive clue that you might be dealing with a really severe hyperinflammatory state called macrophage activation-like syndrome, or MALS. A number like that is basically screaming at you that the inflammation is off the charts.
So what do you do about it? Well, the strategy is actually pretty logical. It's a 1-2 punch. First, you've got to remove the trigger. You can use a filter like a PMX filter to get the endotoxin out of the blood. Then, step 2, you remove the response. You use another filter, like Cytosorb, to literally clean out all those extra cytokines that are causing the damage. It's simple, right? Get rid of the cause, then get rid of the effect.
okay, let's flip over to the other side, the cold phenotype. Here, the problem isn't too much fire, it's that the fire's gone out. The immune system is basically shut down, exhausted. We call this immunoparalysis. And this is really dangerous, because with their defenses offline, these patients are just sitting ducks for any new infection that comes along.
And you can see how the treatment has to be completely different. We're not trying to calm things down anymore. We're trying to jumpstart the system. This could mean giving IVIG to give them some passive immunity, using something like interferon gamma to wake up their immune cells, or even using checkpoint inhibitors like nivolumab to take the brakes off those tired T cells and get them fighting again.
Now, it's not always just hot or cold, so for our third section, let's do a quick look at a few other critical phenotypes you need to know about.
First up, catecholamine-resistant hypotension, or CRH. This is that patient you're maxing out on levo, and their MAP is still in the tank. Their vessels just aren't squeezing anymore. This is when you're reaching for your second-line pressors, like vasopressin or even angiotensin II, to get that pressure up.
Then there's the low-flow phenotype. In this case, the problem isn't the pipes, it's the pump. Sepsis can actually stun the heart muscle. That's septic cardiomyopathy. So even if you get the blood pressure up with pressors, the heart isn't pumping enough blood forward to perfuse the organs. These are the folks who might need the ultimate support, like VA ECMO.
And really, at the heart of a lot of this is endothelial dysfunction. The lining of all the blood vessels gets wrecked by sepsis. This makes the capillaries leaky, which just pours gasoline on the inflammatory fire and makes the shock so much harder to manage.
Okay, so we've got our suspects, these different phenotypes. How do we actually figure out which one we're dealing with at the bedside? Well, that's where we bring in the evidence. Section 4, cracking the case with biomarkers. Now this slide right here, this is your clinical cheat sheet. It's pure gold. It lays it all out for you. On the left, you've got the phenotype. In the middle, the biomarker, your clue, and on the right, the potential treatment, your tool. So for example, if you suspect your patient is in that cold, hypoinflammatory state, you'd look for a low IgG level or a low HLA-DR count. And if you see that, bam, that points you toward things like IVIG. It's a practical roadmap to start personalizing care right now.
And listen, this isn't just some nice idea, there's real evidence behind it. You've got trials like ATHOS-3, which showed that angiotensin II really works for those CRH patients. And look at PROVIDE. That trial literally proved that using biomarkers like ferritin to pick out the right patients for targeted therapy works. The science is finally giving us the tools we need at the bedside.
Which brings us to our final section, the future. We are, right now, moving away from that old, one-size-fits-all model and into a really exciting era of precision sepsis care.
This quote from the paper we're reviewing really says it all. The ultimate goal is to develop targeted treatments that are more effective for specific patient subgroups. That's it. That's the whole game.
So I'll leave you with this question to take on your next shift. The next time you walk into a room with a patient in septic shock, try not to just see sepsis. Ask yourself, which phenotype is this? Are they hot or are they cold? Is this a pump problem or a pipes problem? Because starting to think that way, that's how we're all going to start cracking the sepsis puzzle, one patient at a time. Thanks for joining me.